Good afternoon, everyone. Thank you very much for participating in today's webinar on prescription drug abuse. We have Dr. Renee Lev, who is providing today's webinar. And a little background on Dr. Lev is she's a full-time emergency physician practicing at Scripps Mercy Hospital in San Diego for 21 years and serving as the Director of Operations for the Emergency Department. In October 2012, she established the San Diego and Imperial County Prescription Drug Abuse Medical Task Force with the goals in reducing deaths and mortality from prescription drugs. Her vision is to unite the medical community in changing the culture of overprescribing. Her program on safe prescribing in the emergency department won the 2014 National Association of Counties Award. She has assisted Los Angeles, Ventura, and Orange County to reproduce a similar program in their emergency departments and has helped California ACEP adopt a similar program available to any program in California. She has conducted medical research using Cures database and medical examiner data. She is passionate about this subject and is willing to assist any county or medical practice who wants to do a similar program for their emergency department as well as the rest of the medical community. Before I hand over to Dr. Lev, we have some poll questions for you to look at and answer, and I will display those here in just a second. And the first question is, how many of you or your physicians use Cures, are registered with Cures? Okay, I will close that and go to the next question. Next question is, do you have a medication agreement? Okay, I will go to the third question. How do you pronounce that?
Opioid.
Opioid. Next question is, I avoid opioid and benzodiazepine combination. Okay, I will go ahead and close the poll questions and I will hand over to Dr. Lev.
Okay. All right, good afternoon, everybody. We have a small, intimate group, so I'm going to go at a rapid pace through the slides so we'll have time for questions. Again, I'm an emergency physician. My pain is mostly, I deal with acute pain, not chronic pain, but I've learned from the community at large and is an advocate in changing our medical culture to a more safe practice. I am playing with the slides here. Okay, so what we're going to do is, first of all, explain how we got to this problem, tell you how bad it is, and kind of put you through a quick 12-step program and advice and things that you can do in your practice. We know that this is a big problem. We see here the front page of the Wall Street Journal, a 60-minute exclusive with President Clinton and Dr. Sanjay Gupta talking about young people who succumb to prescription drugs. And we know that the rich and famous have succumbed to all sorts of drugs, and there's a whole list of them that you, I'm sure, see and prescribe in your practice, including over-the-counter. We see Benadryl show up a few times. And it's not just a problem with the rich and famous. Here is a picture of Sherry Rubin and Aaron Rubin. They lived in Poway, where I live. They went to Poway High, where my children have gone to school. And Aaron was one of the best wrestlers at Poway High, had an injury, became addicted to oxycodone, and eventually had an overdose from it. And here's a little video I want to show you about Aaron.
He was full of energy. Full of energy. Loved to wrestle and goof around. Play. He was very lighthearted, fun child. I didn't know what he was taking. It was 220. And the addiction is so strong. These kids don't know how to handle it. Could you get in the chair? I miss you guys, isn't it? We'd much rather have Aaron like this than dead. And a lot of parents don't have that luxury. We can kiss our son at night. What a life, huh? Dad shave you? Yeah. Like shaving? Only yes to no. No. The worst consequence is death. Other consequences are, like Aaron, trapped in your own body, alive, but still unable to communicate the way that you would hope that you could. You also lose all of your hopes and dreams and things that you wanted to accomplish in your life. You can help. Did you ever think anything bad would happen taking prescription pills, Aaron? One for yes, two for no. No.
Help save kids from prescription drug abuse. Secure your medications and talk with your kids. Visit drugfree.org.
So Aaron and Sherry are really my inspiration of getting so involved. A lot of parents or people who have a problem like this or they die get very angry at the medical community. And you've heard some doctor bashing about the problem. Sherry is not one of those. She really has taken a tragedy to become a real advocate, kind of like Mothers Against Drug Driving, but for prescription drugs, and is part of the county-wide task force for prescription drug abuse. So here's a program. We need to change a culture. It's not our fault that we got to this problem. So we have to understand how we got here and how to fix it. So I put things into some steps. And the first one is understanding how we got here. And a lot of pain control has been kind of shoved down our physician throat with Patient Bill of Rights, the fifth vital sign, declaring a decade of control and research. You may have been around back in 2005 when we all had to have mandated CME. And what did we learn about mandated CME from pain? We don't get a lot of message out. Did we learn to prescribe more or did we learn to prescribe less? And we learned to prescribe more. And the other thing we learned is we got rid of triplicates, and so instead of prescribing Vicodin all the time, we prescribed Percocets, and now we have more oxycodone deaths. This shows, the politics behind this. That pain as the fifth vital sign, that came out when I came out of my residency in emergency medicine. That always kind of annoyed me because O2 sat came out before that, and I always thought breathing was more important than pain. It's not that pain isn't important, but it should have been the sixth vital sign, not the fifth. And based on a study of 38 patients, a very charismatic physician was able to push this agenda and fifth vital sign on the medical community, and it doesn't take much to kind of change that. And I use it as an example because he said that this was such an important thing. 10 years later, he has second thoughts. Now we're really pushing patient satisfaction surveys. And it's, again, not that we don't want our patients to be satisfied. That is important. We all need to improve and do better. But, practicing medicine is more like parenting. Sometimes you need to say no, and that makes you a better parent. We're not like Nordstrom's employees where we have to, the customer is always right. And not just for pain medications, but for, an MRI that you want to get done again or anything else. It's a lot easier to write a prescription for a few tablets than to deal with angry patients later, even though that's the wrong thing to do. And thinking about angry patients, we see the ones that are really angry and throwing a fit and writing administrations, but you don't see the whole community of people who are equally as angry, not as vocal, with the prescriptions that we do write. When I go present to the lay community, probably at every meeting, I'll have somebody come up to me and say, I went to the dentist for a cleaning and they gave me 30 Vicoprofen. Can you believe that? And they, take a picture of that prescription, put it on a slide for their next presentation. Or I just went, my wife had an abscess taken out and they gave me 30 Percocets. I couldn't believe it. I didn't need that. So there are, probably more of those complaints, but they're not as vocal or loud. We give a lot of pills out in our society, 10 times more now than we did 10 years ago. And for pain medications, I don't know if we're in 10 times more pain or are we 10 times less in pain than we were 10 years ago, but we provide enough painkillers to medicate 10,000 people around the clock for a month, a lot. And if we think about all the medical problems we have in society, diabetes, hypertension, cholesterol, number one prescription out there, hydrocodone, way ahead of simvastatin. And I call this slide the new meaning of being a superpower. We're less than 5% of the population, but prescribe 80%, 90% of the opioids and illegal drugs in the world. This slide shows a direct correlation between sales of pain medications, deaths, and treatment. So there is a direct correlation. And this is my Goldilocks slide. So we need to give the right amount of medications, the right amount, not too much, not too little. It has to be just right. I had a lady who overdosed on acetaminophen, and I asked her where she got it from. Well, she couldn't talk. She was intubated and going to the ICU. But her husband said it was his prescription. He had back surgery and got 100 Percocet. He took one after his surgery, and he didn't need them anymore. And they sat on the shelf. So we want to give enough to be treated, but not extra to have diversion, and medications need to be locked up. We also have to know what each other are doing. So the primary care doctor may be treating something, then the orthopedic doctor, then the psychiatrist, and then, then you have kidney stones and the urologist comes along, and we create a mishmash of things. We need to be able to coordinate, and that's how you know. So even for me, if I see someone who has a kidney stone, they have a legitimate problem. If they already have 100 tablets, I don't need to add more to that collection. And the other thing about this slide, when you see down there at the bottom where it says 6-methadone for back pain, there's a campaign teaching children that one pill can kill. And here's an example of that. Again, a patient who came to our emergency department, day after day, please, please, please help me. My doctor's out of town, every other excuse. And, it's just easy to succumb to that. And the ER doctor agreed to write for 6 tablets of his methadone, and he died. And his parents didn't like it, and they sued, and it's just ugly all around. Our drugs that we give, that prescriptions that we write for, don't end up in the right hands. The leftovers get diverted. Vicodin, the number 2 misused drug out there, second only to marijuana. For high school kids. And here's a slide from the CDC showing that, of all the prescriptions we write, 9 million medical users, 5.3 are non-medical users. So those are being used for other things. And this slide shows that there is a real street value for those prescriptions that we write for. The emergency department, kind of step 4 in the process, to keep track of the patients that I see, and maybe 20% of them are there for some type of chronic pain condition. They don't come, most of them don't say, hey, I need a refill of my Vicodin. Some do. They've learned not to. They'll say, the stomach ache that I always have, the headache that I always have, the back pain that I always have. And it could be draining. In order to do the right thing and kind of change our culture as physicians, we also have to understand the issue of chronic pain. And we know that if you step on a rock, you have receptors that go to your brain, and your brain says, ouch, and it hurts. But after a while, when you're on these drugs for a long time, your normal pathway stops working. And we all know that the more you need, the more you need. So you have, it fatigues, so and the receptors are no longer as active, so you need more and more of the medication. But after a while, that whole pathway is broken, and you may have seen patients where you barely even touch them. I don't even have the stethoscope on the skin yet, and they're in pain. And that's opioid-induced hyperalgesia, and the treatment for that actually is taking less medications, not more. And there is serious question of usefulness of continued opioid use for chronic pain. There's one clinic in town in San Diego that actually has had it as a policy that for, muscular chronic pain that's going on for a long time, they will no longer be using opioids because the problem of pain is real, but the answer for that is not just more and more drugs that could eventually kill you. JCAHO has really understood this issue, and there's a mandate that you have to acknowledge pain, but there's no mandate to get the pain to zero. Zero is intubated on a ventilator or dead. We just have to address it, and there's no mandate to treat it with opioids each time. There's other modalities. So I like this slide because we said the physician who did the fifth vital sign advocated the use of opioids and said nobody gets addicted at his 38-patient study. And here's a slide from the CDC showing 100% of patients on opioids will develop dependence. We know the red flags. When you're writing a prescription and you're kind of rolling your eyes and have that gut instinct that something's not quite right, you should be checking. Sometimes you're wrong, and then you're happy to be writing that. But we have a problem with doctor shoppers, patients using multiple medications, multiple providers, repeatedly running out, losing your prescriptions. If you lose a controlled prescription, you need to call the police. That could be a crime. And people who say, I'm allergic to this and this and this, and this doesn't work for me, this and doesn't work for me, I only need this brand name. Cough medications is a common request. There's opioid risk tools this is not so much for in the emergency department, most in chronic practice. If you're seeing patients who need these medications again and again, there's this tool, and then there's other ones that you can be using as far as how much of a risk this is. I think it's not only the risk, but also the combination of other medications that our patients are on. And then we have deaths, 105 deaths a day in our country. It's ridiculous. If this many seals were washing up on the shore, we would be outraged. But these are human lives, and one every other here in San Diego. So it's too much. And the next few slides, I want you to just to kind of look at the colors. So if you see 10 years ago, most of the slide is blue, and now 10 years later, most of it is orange. And that's the increased number of deaths over the past 10 years throughout all the different states. And in California, we have the same kind of map that comes from the CDC. San Diego is a little high as far as higher in deaths per 100,000 than the rest of California. And in this slide kind of shows you that the number one cause of non-accidental deaths in our county is drugs. And you see that has gone up in red. Suicides go up too. These are the one I say number one cause of non-accidental deaths. That doesn't include the suicides. Some of those are from drugs as well. And this slide I call "Who Needs Heroin, Cocaine When You Got Vicodin and Percocet?" Because the deaths from opioids that we prescribe are more than double than the other drugs combined. And death is just the tip of the iceberg. For every death, there's ER visits, abuser, non-medical users, and extreme problems with society. So when I used to give these presentations, physicians would always tell me, if patients just took the drugs like I told them to, then they wouldn't die. And so I wanted to find out if that's really true. I took 254 deaths from the medical examiner's office here in San Diego County that they deemed were caused by prescription drugs, unintentional, not suicides. And I worked with the office in Sacramento to run a cures report for 12 months from date of death. Now, a cures reports you probably are familiar with, they have only outpatient data. In our county, they wouldn't include Balboa naval-based methadone clinics, the VA, or the hospital. And from those 254 deaths, 186 had some medication from cures. 68 of them died from medications that they got outside the cures system. And looking at those medications, I could split it up through every single drug and find out the number of deaths, whether they were a match, whether they actually died of the same medication, because sometimes we prescribe things and then the patients die of something completely different, and how many prescriptions, and how many patients got it. So, for example, looking at hydrocodone, the medical examiner showed 48 deaths. Out of those 48 deaths, only 24 of them had a match, really got a prescription from a provider 2 months before deaths. 16 of them had a cures report, but it didn't include hydrocodone, and 8 patients had died but didn't have any cures report at all. And looking at hydrocodone separately, just in cures, there were 990 prescriptions written for all 254 patients during that year, and for 123 patients. And so we have that. And if you notice, there's people die of things that we don't write for. Benadryl, 28 deaths from Benadryl, an over-the-counter medications. Gabapentin, something else that tends to be abused, and other drugs like that. So PDMP match, that means how many, PDMP is another word for cures reports. It's a prescription drug monitoring system. So in other states, that's kind of the vocabulary. And in California, we use the word cures. But I wanted to know which patients actually died of the medications that we gave them. So, for example, out of the 254 deaths, 100 of them, 40%, actually had a drug that was prescribed to them 2 months before they died. But if you take out the ones that weren't using alcohol or any other illicit drugs, that goes down to 68. And even if you take out the ones that were doctor shopping, seeking, by that I mean a research definition, meaning more than 4 doctors and plus 4 pharmacies, then that goes down to 42. So only 16.5% actually have died kind of by being compliant. I can't prove that they actually took that same medications, but in general for those definitions. And that population of 42 patients, that quote-unquote compliant population that died supposedly following instructions, have a different demographics than the population at whole. The population at whole is mostly male, and this one is mostly female. The compliant, the cures match population is a little older. They have more prescription, less providers, less pharmacies, because they're not the doctor shoppers. They die more of a single medication, such as methadone, and I'll be mentioning that, and have higher morphine equivalents and long-acting opioids. Chronic use, I have this slide because I chair the Prescription Drug Abuse Medical Task Force at the county, and we bring together various providers from across San Diego, with the Scripps and UCSD and Sharp and Kaiser and the community clinics. And we created a medication agreement that's been translated with health literacy, so it reads at a 5th grade level. And we promote using the medication agreement for chronic use. I mean, chronic use means if anybody who needs a prescription for 3 months in a row or more should have a medication agreement, and we call it a medication agreement, not a pain agreement, so that way the psychiatrists and people who are using it for your Adderalls and benzodiazepines can use it as well. So out of all the prescriptions for the patients who died, 69% of all deaths were people who were chronic user, and they consumed 96% of all the prescriptions. So there it is. And if you look at general demographics, if you can see the small little bar graphs for California and San Diego, I took our total population, every single medication that was given in 2013 from the PDMP reports, and for 3 months or more. And you see in California 2.8%, and in San Diego 1.6% of all our population are actually chronic users of medications. But of the deaths, that's almost 70%, so it's much higher. Methadone gets its own slide because I also advocate to the methadone clinics that they need to be checking cures. They are not allowed by federal law to enter their data of cures, so those patients can be seeing you and double dipping, and you won't know, but they're allowed to check and should be checking. And of the 46 deaths that occurred from methadone, only 85 occurred from cures. So only 7 patients got their drugs from a cures source. 39 or 85% of them got it outside our normal prescribing area. I mean, they could have been the VA or Balboa or somewhere else, but it was outside a cure source. But honing down to those 7 deaths, all of them occurred from primary care doctors. None of them occurred from pain specialists or psychiatrists or ER doctors for 2013. And 6 out of 7 of them got the prescription filled within days of dying. And methadone is different than the other opiates. It's a long-acting medication. It's got a long half-life. If someone wakes up from Narcan, from methadone, they'll just go back down. I mean, we have to admit all those patients. So that's why it gets its own slide. Opioids and benzodiazepines. This is known to be a deadly combination, and yet I see it time and time again when I see patients and I go through their medication list as an emergency physician. I'll just say, you know what, you have some medication interactions. You should talk to your doctor about it. And they're 2 depressants together. And if we look at all 186 patients who got a cures report, more than half of those had that type of combination. You see that in the first pie graph. And if you look at the actual patients who died, well, okay, so everybody's getting a combination, or a lot of people are getting combinations of opioids and benzodiazepines. The majority of cures reports show that combination. How many of them are actually dying? So out of those who had opioid and benzodiazepine death, there was less of those. There was 55 who actually died from that combination, and majority of those actually had a match, were taking it as they were supposed to. But I'd be very weary, and the VA system now in San Diego is not allowing this combination, to the chagrin of the psychiatrists. Patients have to choose, and some of our community clinics also. It's like one or the other and not 2. The Holy Trinity, I have that there because this combination is a greater, faster way to get to heaven. I've seen that prescribed from my own hospital, unfortunately, and again, not a good way to be, and for several reasons. One, Xanax. Xanax is not recommended for long-term care, according to the American Psychiatric Association. After a few weeks, it's not as effective. So it's for an acute panic attack. It's not for being on it month after month after month. If you do, then choose a different benzodiazepine. It's nice for panic attacks because it works rapid onset, but it also doesn't last as long, which is why patients get addicted to it and need more and more. So you need to use something that's more long-acting. Soma, I think, should just be off the market because it's off the market in Europe and other countries. People prescribe it as a quote-unquote muscle relaxant, but you have no muscle relaxant effect when you get it because it's quickly metabolized to a tranquilizer, a benzodiazepine that's extremely addicted. And so you have all the addiction and none of the benefit of our muscle relaxants. If you need one, then use something else. And again, not a good combination. Many pharmacies in town, if they see this Holy Trinity, they'll give you a call and ask you to explain why this patient needs this combination. And where do pills come from? Do they come from the street? Are people selling them? Are they buying them? Are they coming from the internet? And kind of like teenagers with alcohol, they get it from their family and friends. This is where drugs come from, family and friends, but the majority, all of them, are coming from us, from one way or another, is coming from the providers. So here are the studies from San Diego. So these are all kind of my friends and colleagues in San Diego. There were 713 providers who wrote for prescriptions for on those 186 deaths that came from a cures source. And you could see that the majority is coming from primary care. Another thing that physicians tell me when I talk about the subject, it's like, well, those pain doctors, you should see how many pills those pain doctors are giving. Well, the death data doesn't show that. The death data shows that it's still, the majority is coming from our primary care providers. Emergency is the number 2 people who are getting sources. Then psychiatry, and the least amount is pain, dentists, and surgeons. And let's look at what is actually being given. So if you look at the percent of all the pills sometimes matches the number of providers, the denominator, but sometimes doesn't. So if you could see there, primary care gives the most number of prescriptions and also the number of total pills out there. For the first two bar graphs that you look at. But what surprised me is psychiatrists actually, which were a smaller denominator than the emergency physicians, give more pills total and more prescriptions. And you could say, well, they give a lot of benzodiazepines, and I'll show you in another slide that that's also not true. They actually give more pain pills than emergency physicians. And psychiatrists are down there, and actually the pain physicians are down there. The bar on the right, I'm actually going to make it a new slide on its own, because I think that tells you whether you're kind of prescribing like the rest of your colleagues are. So the average prescriptions per, average pills per prescription is 75 across all our specialty. But me as an emergency physician, for patients who died, the average was 23. You know, there were some that was up to 60, and we write as little as 3 or 2, but the average was 23 pills per prescription. And you could see that the surgeons give the most, and maybe rightfully so, they 123, and the pain doctors are down there or up there at 97. But that helps me, because when I have a patient comes in to the ER like I did the other day, and she has a prescription for 300 and she ran out, it's like, I'm not gonna, that's just wrong. I'm not gonna be part of this. If there's somebody there giving you 300, I'm not gonna add to that collection. And where do doctor shoppers? So who do the doctor shoppers like the most, I guess, out of this? If you look at the red number 51 in the middle, you could see the ones on the right, like the emergency physicians, ENT, urologists are more, and actually nurse practitioners more than physician assistants. Neurologists stand out there because they give the most number of prescriptions per doctor shopper compared to the rest. And if you're a urologist, the patient that died, 100% of them were doctor shoppers. And it would make sense, because a urologist is usually not the first line of, you've probably seen several other doctors before that, but that just tells me that I need to teach urologists that they should be checking cures, because even patients have a legitimate kidney stone, if they already have a whole bunch of medications, you don't need to add more to that collection. And this shows, okay, let's divide it by types of medication: opioids, benzodiazepines, stimulants, sleep aids, who's giving each one of those. And you could see for opioids, primary care is number 1, and followed by surgery. And this is percent of prescriptions, not pills, because actually the number of pills psychiatry was higher than emergency medicine. And for opiates, pain specialists are only 8%. And the stimulants, you could see, are only primary care and psychiatry, none of the other providers, which makes sense. And I could also say that none of the patients who died from a stimulant got them from a cure source. They got them from outside of a cure source. So what do we do? What can we do about that? Well, when there's a problem, government is going to intervene whether you like it or not. And if we don't own the problem and create change, then they create change for us. Some things we like, some things we don't. And one example of that is a changing of the hydrocodone schedule this year. California has responded with the Cures program. So I would hope that by the end of this session here, you would encourage all your colleagues and yourself to get a Cures account. It will be mandated in 2016 for all providers to have a Cures account, and it simply just makes you a better doctor. For me, it's like checking allergies before you give a medications and before you give a controlled substance. See what other people are giving and make sure that you're doing the right thing. When your account is working, and I realize it's a problem, it's wonderful. It really doesn't take that much more, and it just makes you a smarter, better doctor. If any of you have an account that's broken, tell Veronica afterwards, and I'll help get it fixed for you. And coming up for 2016, there's going to be a Cures 2.0 that will work better, and it'll have dashboards of how many morphine equivalents your patients are on, and it'll be an even better system. So right now it kind of gives you, if you Google Cures login, you could find it and keep it on your screen or your computer while you're working, and it'll be nice. With the new system also, you could have your office manager, if you know patients are coming in the next day, you could have your office manager have what's called a child account and be able to run these reports for you, and you will have them with you, so it shouldn't take any time from your regular time of seeing patients. We have worked with our public health department here in San Diego. Our public health has been deputized to be a Cures registrant. So typically you have to go get notary to turn in your paperwork. But if you go to the Office of Vital Records, no appointment, 9 to 5, Monday through Friday, with your paperwork in hand and a copy of your license and registration and paperwork, they'll do that for you and send it in without requiring notary. I ran these Cures report, and I thought of it as death diaries, because my job is to keep patients alive. Anybody who dies, it's a defeat in our little department. And looking at these patients who died and seeing the prescriptions that they have was a little bit morbid. And here's an example of a 56-year-old lady who had 23 prescriptions by 10 providers and dying, right before her birthday. She didn't get anything February and March. Then she went to the ER in April, and a primary care doctor kept getting medicines month after month until she finally got a primary care doctor who started her on methadone. And she got methadone month after month, didn't get it in January, got only 30 pills in February, and then died. And in her system was the methadone that she got just right, a few days before she died, as well as Dilantin, clonazepam, carbamazepine. And interesting enough, she was getting lorazepam every month, but that's not even what she died of. She died of a different benzodiazepine. And there's so many ways you could think about this, of how this could have been prevented. What we've done, I told you I chair this medical task force, is really trying to create a one San Diego culture. So whether you are an ophthalmologist or a primary care doctor or a dentist or an ER doctor or a pain specialist, it doesn't matter. We want to have like one message for safe prescribing. Simple things like not sharing your medication, using only one provider and one pharmacy to coordinate all your medication needs. Don't drive if you're impaired. If you lose your medicines and then or if they're stolen, file a police report. Don't go to the ER to refill these medications. To have some simple message. And then we're learning each time we meet with our task force of how different institutions are handling this problem on a patient end and also on a provider end. The VA system in Kaiser has an elaborate system also for educating and monitoring their physicians and compliance. For example, in Kaiser, they want all your prescriptions to write, I expect this prescription to last for 2 months. So it's not that you wrote for 30 tablets, you should be out of them within a week. They require their primary care doctors to be that specific when they write their prescription. We publish our report card on an annual basis, and this has been a model. Now other counties are copying it as well. And included in number 9 is the number of pills for opioids, benzodiazepines, and stimulants, and we see how that keeps rising each year. And we work with the coroner's office to see the number of deaths as well. And I'd like to see those go down with and for the medical community to do our end of what we can. And it's such a multicultural problem in our society, but the medical community can do our little piece to make it better. We have provider guidelines, and I encourage you to visit our website, which is sandiegosafeprescribing.org. sandiegosafeprescribing.org. It's a page under the San Diego Medical Society that provided this, and we have all these guidelines and medication agreements and other educational information on there as well. And the guidelines are very clinically based. There's guidelines that were written by the CMA and the medical board, and of course I'm biased, but I find these, this is what to do for acute pain, chronic pain, things not to miss, things about, tramadol. Physicians think that, oh, this is a non-opioid, but it is an opioid, and it is addicting, and patients die from it, and it actually has more morphine equivalents than a Vicodin. But it's been advertised as a synthetic and non-addicting, and that's just not true. Avoiding, a lot of patients ask for cough medications, cough syrups to help with their cough, and I provide inhalers. Why do you want to keep your stuff in your lung instead of getting it out of your lung? But apparently, and these are all things that I learned, it's a very abused medication. People, pour it in their cocktail and kind of sip it along all day. So be aware of that. And again, those guidelines I think are useful. Here's CDC guidelines that are all incorporated into our guidelines. The medication agreement, we wrote it on a 5th grade reading level. We rolled it all out in a nice long version, and then the community clinic doctor said, hey, we can't do all this in our short appointments that we have with our patients. So then we went back to the drawing board, wrote a shorter version. So now we have a short version, a longer version. You may have your own version. This one has, logos of the county, and it's been endorsed by the Hospital Association, Medical Society, and Public Health. And again, it unites our community, and it also sends a message that, when you start a medication like that, there are responsibilities and risks that go along with it. And mainly one provider, one pharmacy, we can't be having all these different specialists giving different things without, knowing what the other one is doing. And this safe prescribing campaign we have it in every single emergency department in San Diego. It's now in 77 emergency departments in Los Angeles, Ventura County, other places. And it sends a similar message in, simple language that the emergency department's not going to be refilling. We want one provider, one pharmacy. We're not going to give any long opiates. We're going to check cures. We may ask for photo ID. And it doesn't take away our clinical judgment. I have written for, MS Cotton for a cancer patient who got discharged from the hospital and couldn't get her refills. We're allowed to use our brain. But in general, it sends a nice unifying message. What happened before, they would be what I call the candy man. He's like, oh, I want Dr. Smith on today. He's really nice, and he gives me everything. And then we had the candy land. Everybody was going to Grossmont Hospital. It's like, hey, what's going on here? It's like, well, everybody else is doing this program, and you haven't yet. So it's really united the community, and we poll the ERs on a regular basis once a year, and the number of drama and scenes, and even number of patients who have these requests have gone down. So it's made our life easier as well. We've now rolled it out in many of the urgent cares around town are using it as well, and it's the same kind of orange pink colors that you see kind of around California. So it's not like you're going to be able to go from county to county or ER to ER. They see that and realize that, hey, everybody's kind of following the same safe guidelines. So there are what you can do is there's nice ways of saying no, and I have them also available on the website, but patients ask you for something for pain, you could always say, yes, let me check the best choice. It gives you the chance to go look. If a patient says something doesn't work for you, it's helpful to know, well, tell me exactly how you're taking the medicine. It's amazing how good Motrin and Tylenol is, and they've done studies actually that, the numbers needed to treat for regular, not chronic patients who are used to it. Tylenol and Motrin as a combination works even better than tramadol or low doses of morphine. And we're running out of time, so I'm going to go ahead and tell you, kind of sum it up with things that you can do. One is use the cures. Use it like you would for checking allergies. Prescribe the right amount, not too much, not too little. You don't want leftovers. One trick that I've learned from the pain doctors is they check yours, and if you already got pain pills you got 20 from the ER, and you were supposed to get 120 this month, they're going to get only 100. They subtract that. Don't mix benzodiazepines and opiates together, or be very careful, or understand that there's an added risk when doing that. Know that tramadol has more morphine equivalents than Vicodin. It's abused and people die from that. Using a drug screen when you refill prescription helps you to see if the patients are compliant, or if they're using other street drugs and you shouldn't be giving them medications, or if their drug screen is negative, then where are those medications going? Either they're running out or they're going somewhere else. Use a medication agreement. One of the things I have found from one of the Sharpie-Steele clinic doctors were saying that, wait a second, these patients are on agreements and they come in for their refills. It's a free ticket for more drugs, so be careful. It's not a way for you to turn your brain off. If someone's had an accident 10 years ago and they're still needing this every month, then you need to still reconsider things, but it still helps in establishing guidelines and risks for doing that. Use our website for resources. Pain scale is nice, 1 to 10, but also a functional pain scale. So my patients have an 11 out of 10 pain, but they're texting and eating chips. It's a little bit, it's a different description. And cooperating with the DEA, if you get a phone call from a DEA, chances are you didn't do anything wrong, because if you're under investigation, they'll be doing that with their secret cameras. If you're getting a call from DEA, they want to find out if you've been a victim of fraud. If your patients have been coming to you saying, oh, this hurts me, I don't have any doctors, and they'll ask you questions like, if you knew that this patient was getting all these drugs from somewhere else, would you still have given these, 30 tablets? So don't be worried, and help them. And we use them actually to help get patients into court-mandated rehab if there's nothing else to do. So this is the website, SanDiegoSafePrescribing.org, and I think we if this was so interesting for you, there's another conference coming up March 11th, a free conference, again, to send the One San Diego message. So I encourage any of your friends who may want free CME, free lunch, to attend this symposium as well.
Okay, it looks like we have some questions that have come by. Let's see here.
How do you read them to me? 'Cause I can't.
Yeah. So the first question is, obviously there is a primary care physicians than any other specialty. Is there info about the average pain prescription per doctor per specialty? That's the first question.
Yes, I have that, and I think, let's see, will this go backwards?
Mm-hmm.
So if you look at the right-hand bar, you'll see for primary care it was 79 average pills. This one doesn't differentiate if it was opioids or benzodiazepines or something else, but it's 79 per prescription compared to surgery that was higher, and for emergency medicine that was just 23.
Okay.
And these are for patients who died. So I would imagine, it may be a picture of the larger population as a whole, but maybe not.
Another question here is, based on the map, looks like the highest areas are the hot pot growing areas. Is there a relationship pot use, RX abuse? Yeah, so that's the question there.
Hot or pot?
It says hot pot, quotation marks, hot pot, growing areas. Is there a relationship, pot use versus RX abuse?
I'm not sure if I quite understand the question. I see hot and pot. So my answer to hot is, I actually have it on our website. We have a map of San Diego by zip code, and if you practice in East County, you are giving more, in general, opioids, benzodiazepines, and stimulants than the rest per population. So East County is needs more to tone it down on their prescribing than the rest of the county. As far as pot, as of date, the medical examiner's office doesn't include marijuana in their annual reports, and I'm working on them to change that, because You know, there are things, oh, well, marijuana doesn't kill. Well, who thought Benadryl kills? If you don't measure it, you won't know. So hopefully that will change. And other studies have published that if you're some of the community clinics, and I know like Indian Health, which is a federal clinic, if you're using marijuana for pain or something else, you cannot add a controlled substance to that, period. So it'll be choose. If you need marijuana for your pain, then fine, but then I can't write you for your opioids. So you have to choose one or the other. Some physicians feel differently about marijuana. Just realize that if you're adding marijuana to the opioids and the benzodiazepines and their Ambien, then you have multiple suppressants there, and you don't want your patient to end up as a statistic.
Okay. Why do NPs and PAs not have Cures account?
They do have Cures accounts. Anybody who has a DEA, pharmacists, nurse practitioners, PAs, they have Cures account. Our nurse practitioners and PAs who work at our emergency department have accounts. So yeah, you could fix that.
Can we get a copy of your pain contract?
Sure. If you go to San Diego Safe Prescribing .org, there are two versions of the medication agreement, and they have the logos of the Medical Society, Public Health, and Hospital Association. There are two versions of it, short version and a long version, and in English and in Spanish.
Okay. Next question is, I have a patient who was on a PRN pain medication and PRN Xanax, complained to her insurance company that I was seeing her too frequently and doing unnecessary drug tests. The insurance had the audacity to get my medical records and ask for an explanation. It was a waste of my time.
You know, welcome to all of our worlds. A lot of what we do, I mean, before I came here, I had to take a test to show that I knew how to take a hemoccult specimen. So in our profession, unfortunately, there's a lot of stupid things we have to endure. If you can imagine if you were on the other end and you were the insurance company, some patient complained about something, you have to respond. You can't say, oh, this is a stupid complaint. You have to, you know, you're not a medical person. You have to follow through. And I wouldn't let that hold you back. We had one of our doctors also, a patient complained to the medical board, which that patient was a stalker, and he had to, you know, get a restraining order on her. Don't let things like that prevent you from doing the right thing. And when I see patients who are on Xanax and opioid together, I tell them don't take them at the same time. Since those two are on PRN, then I'll say don't take them together and don't drive.
Okay, it looks like we've covered all of the questions. If there are any other questions, please send them through now. Let's see if we can share this. Okay, we can share the poll questions and answers. And let's see here. The first question is, I avoid opioid and benzodiazepine combination. And it looks like 100% answered yes. The next question, how many of you or your physicians are registered with Cures? And it looks like we had answer 100%. I use it all the time. So that's good. And the last question is, do you have a medication agreement? And it was 50-50. It looks like one answered no and the other answered, I use my own agreement. So I don't know if you have anything to share on that.
No, it made me think of it. One of the things about those Cures report, it's, as always, I'm talking to people who are already involved, and that's why you're on this webinar. But I really want to reach the community at large, and going through those Cures reports on patients who died was really remarkable to me, and thinking that if these doctors knew that their patients died, that may really change their practice. It's not like your prescription killed someone, but you added to the collection that ended up in a demise. And so we're working with the medical examiner's office that if there is a death, you will be provided, and now you have to run your own cures report so you can see what was given after the patient died, to see, you know, how you could think or do things differently. Maybe not, but at least you would know what's happening.
Okay, great. Well, Dr. Lev, I want to thank you very much for presenting today. And since we don't have any other questions, we will go ahead and conclude today's webinar. And thank you very much for participating.